public health specialist from the Western Cape Department of Health and the UCT School of Public Health. So over to you, Marianne. Thanks very much.
Thanks again for the opportunity. And I think we can go straight to the next slide. So as of today, we are sitting at 24,500 cases in the Western Cape. And just in the last 24 hours, we had nearly 1,500 cases diagnosed. And I remember it feels like just yesterday that we got to 1,000 cases in the Western Cape, several weeks after our first case was diagnosed. So it seems remarkable that we can have well over 1,000 cases now just in 24 hours. We know that with the change in the testing strategy in the metro, limiting to hospitalized patients and those over the age of 55 or with comorbidities, as well as healthcare workers and people who are residents in long-term facilities, that number of cases may no longer be a reliable indicator of the number of people with COVID in the Western Cape, even to the extent that it has been somewhat reliable, and that it may flatten but not indicate that the epidemic is not increasing. Also, we have 600 deaths now recorded across the province, and yesterday the MRC reported that we had breached the upper limit of what is expected for this time of year in terms of natural deaths for people over the age of 60 years. So the impact of COVID is certainly being felt, I'm sure, across the clinical platform in a very major way, but is also actually being seen just in overall mortality. We can move to the next slide. Speaking of the clinical platform, the next thing we're going to look at is hospital admissions. And this is quite a busy graph, but the blue line shows general hospital ward admissions. And 2 weeks ago when I presented, we were sitting at about 55 admissions per day. Now we're probably sitting at about 90 admissions per day, but the flattening off on the right-hand side there is partly due to a lag in reporting and may also reflect some rationing and discretion in terms of who is being admitted. Usually we do see this flattening off in the last few days, and then when we look a few days later, we see that there was actually no flattening off. It was just due to a lag in reporting. If we look at ICU admissions, we see that they've actually, which is the orange line, they have not changed much from 2 weeks ago. We're still sitting at about 10 admissions per day. But if you look at the green line, you can see that the proportion of patients being admitted to ICU has decreased steadily, and we're now sitting at about 10% of patients who are admitted to ICU. And then looking at deaths, which is the black line, we are routinely in the last week or so getting at least 20 deaths a day. And again, the flattening off there probably represents a lag in reporting and not a real flattening in deaths. We can move to the next slide. Just very quickly to cover testing, you can see that the number of tests really hasn't changed over the last few weeks, showing that we have reached the upper limit of our testing capacity. What has changed somewhat is that we really aren't doing much in the way of community screening and testing. The dark green bars have almost disappeared on the top left. And if we look at our positivity, it is steadily increasing. Last time I presented, we were at about 20% positivity, and now certainly for our public sector tests, which are the two green lines, we're sitting at 30% positivity. And if we look just in the metro sub-districts at tests done in the last 2 weeks of May, we see that across almost all the sub-districts, we are at 30% or over positivity. This probably reflects a real increase in incidence of COVID, but also that there is increasing selectiveness in who actually gets tested. And we can go to the next slide. I've kept the overall epi very brief for this week because what I'd like to do is to share some preliminary analyses looking at risk factors for COVID-19 death and a particular focus on the risk factor of HIV in our setting, given that obviously this is a key comorbidity and also that there's been very limited data on large cohorts of patients from other settings. So because our COVID data is linked to all of our other provincial data, we were able to put together a data set of about 3.5 million patients who we can consider active adult patients in the public sector. And we have history of their comorbidities based on what we can infer from either laboratory testing, drugs received, or encounters in the public sector. So importantly, the comorbidities that are easy to infer from these are those listed on the slide, but we are missing key comorbidities. The big one in relation to COVID is probably overweight or obesity, but also other potential comorbidities such as smoking and cardiovascular disease, and other comorbidities where either there isn't a key diagnostic test or the particular drugs used are not definitive of a particular condition. And I'm going to very briefly present three analyses. The first is looking at, among all those public sector patients, the factors associated with COVID death. This is essentially the same approach as was taken by the Open Safely paper, which I'm sure many of you have read, looking at COVID deaths in the UK NHS patients. The second is looking at factors associated with COVID death in public sector patients. And the third is looking at the standardized mortality ratio comparing HIV positive and negative. And we can move to the next slide. Because I'm focusing on HIV, I wanted to share that we've had, as of a week ago, over 50 patients who have died with HIV in the province. But importantly, these are patients with substantial other comorbidities. So these are the proportion of deceased patients who have each of the comorbidities listed below. And this is not based on our data center data, but based on actual capture of comorbidities at death. And importantly, we do think that there is substantial under-ascertainment of some of these comorbidities, particularly obesity. If we compare the number of comorbidities between HIV positive and negative, we see that the HIV positive are more likely to have 3 or more comorbidities. And one of the reasons for this is because so many of them have previous or current tuberculosis. And so that sort of immediately gives them a +1. What I want to highlight is that what we have not seen is large numbers of patients with advanced HIV and severe COVID. And that's despite the fact that 40% of people with HIV in the province are either not on ART or unsuppressed. We can move to the next slide. So this is, and the most important words I think you probably can't see, were in red at the bottom of the slide, but I will say them and repeat them. This is the population level analysis looking at the 3.5 million patients and factors associated with dying from COVID. We see the expected effects of male sex and age, and we see that almost all the non-communicable diseases do have quite a strong association with COVID death, and that both previous and current TB are associated with COVID death, and then about a 3-fold increase in risk for people who are HIV positive. The bit that you can't see, which is in red at the bottom of the slide, is that this association probably represents the absolute upper limit of any effect of HIV, and that there may be substantial residual confounding, particularly by obesity, but also by the fact that people living with HIV may have other socioeconomic, demographic and comorbidity profiles that make them at higher risk of death independent of their HIV. We can move to the next slide. Here we're looking just at the COVID cases, so just under 9,000 of these. What we see is that the effects of all the comorbidities are attenuated when we restrict to cases. We expect that because we are restricting to a subset of patients who had sufficiently clinically severe disease to actually present for testing. And we know that we are only testing symptomatic patients. We still see about a 2-fold increase in risk with people with HIV, but my red cutoff words remain important, that this is the upper limit of any effect. And if we move to the next slide, we tried to explore whether this effect differed by age. One of the reasons for doing this is that we noticed among the public sector patients, half of those patients under the age of 50 who had died were co-infected with HIV. And if we start comparing, we've got the younger age group on the left-hand side and the older age group on the right. What you can see is that the effect of all the comorbidities is attenuated in older patients, which is what we expect because older people, age alone is such a large risk factor for death. And that really there isn't any significant effect of HIV, but that in the younger patients, the effect of all the comorbidities, including HIV, is increased with a hazard ratio of around 3 for HIV and a significant interaction with age. And then the next slide. This is just to highlight that although this relative increase might seem quite big, we need to remember that the risk of death in younger patients is really very low. And so while we might be seeing a large relative effect, the absolute difference is actually pretty small. And we're talking about moving from a just under 1% probability of dying in the younger patients to about a 2% probability. And the next slide. And here we're looking at trying to tease out if there's any effect of viral suppression. And what we can see is that in really, irrespective of whether patients are virally suppressed, whether they've started ART but are not currently suppressed, or whether they have never been on ART, that increased risk of mortality remains at about 2 among the cases. So it's pretty much the same. And I think what this tells us is that whatever effect we are seeing here is complex, and it's not a simple story of patients without virologic control and with immune dysfunction, and that's putting them at increased risk of COVID death, but that there's something more complicated than that going on, potentially related to HIV and risk of comorbidities and the residual confounding that I've mentioned. And I hope I've driven home, despite the fact that my red words got cut off, that there are several limitations here with particularly no information on obesity. And then the last slide, which is looking at the standardized mortality ratios. So this is a much more kind of population level look. And to date, we've seen about 104 deaths per million in our HIV positives and about 46 deaths per million in people without HIV. And we use that to calculate the standardized mortality ratio, which is the ratio of the actual number of COVID deaths in people with HIV compared to what we would have expected if they had the same risk of death as HIV negative people of the same age and sex. And we can interpret this like an adjusted risk ratio. And importantly, whereas the other analysis only took into account the public sector, this includes private and public. And we get an SMR of around 2.6, which reassuringly is fairly similar to our population level analysis. And I'll leave it there, except to thank all of my usual suspects, and particularly Lee Johnson, who was responsible for the SMR calculations. Thank you.
Thanks, Marianne. Once again, really brilliant to see that update in real time as the epidemiology becomes known in our setting. And one of the concerns that we as clinicians had was that we would see a huge number of patients with advanced HIV being admitted with COVID. We are seeing obviously some of those patients, but it is reassuring that HIV itself is not massively amplifying the morbidity and mortality associated with COVID. Marianne, if I can just ask one question before we move on to the main session. The issue around the change in testing strategy, obviously that's been necessitated by the huge backlog in the testing being done in the laboratories. But it will impact on our ability to monitor the epidemic. And I'm just wondering what metrics you are going to be now using to monitor the epidemic through communities in the Western Cape, now that we can't rely on the community-based testing.
Yeah, so I mean, I think that's a huge challenge. The one, our best metric is death, and we will continue to monitor that as best we can, and are very actively pursuing having better access to home affairs data. Obviously, the hospitalized patients also remains a good metric, and those will continue to be tested. And I want to highlight that the change in testing strategy is only for the metro And in rural, the testing strategy remains the same. So in rural, that's particularly important because their outbreaks are really only just starting, and we will continue to monitor that. And then we are exploring, there is still going to be very active symptom screening going on, and we are exploring the use of various of the data platforms to capture that symptom information so that we at least have a sense of the probable cases that are being diagnosed. And if we ever shift to a situation where even hospitalized cases are not all being tested, we have a mechanism for incorporating that through both ICD-10 coding, which I would encourage people to use, as well as ward of admission, so that test result is not an absolute requirement.
Great. Thanks very much again, Marianne. So we move on now to our main session this afternoon, which is an interactive discussion around the chest radiology of COVID-19. And I think this is a very exciting session, really tailored for clinicians to bring them up to speed with this issue. Obviously, in COVID-19, we've encountered a completely new disease. And it's been a steep learning curve within the clinical services around the spectrum of radiological findings and the interpretation of the chest X-ray and CT scans. Our teams at Groote of clinicians have really been supported and kind of been learning this in close liaison with our radiology colleagues. Kanita Said Hartley and Sulaiman Musa has really supported us in the clinical services. And in this afternoon, we really wanted to share these learnings with a broader audience on this webinar platform. And so Kanita has kindly agreed to engage in a discussion with 3 clinicians working in our service. The format is going to be that Kanita will provide an introduction covering some of the key concepts around the radiology of COVID-19. And after that, we will have around 10 case presentations. The cases will be presented by Sean Wasserman, who's an ID specialist at Groote and UCT, Linda Baloko, a specialist physician working in the COVID service, and Tari Papavanavas, who is a physician and an ID senior registrar. So Kanita will present the introduction first, and then we'll go straight on to the cases where the 3 clinicians will present a few of the cases that will illustrate the spectrum of severity, some of the findings when there's comorbidity, and some of the complications that we see in COVID-19. That should take us to around the top of the hour. As Mark said, we probably won't have time for questions from the chat room this afternoon, but we hope that the interactive case format will provide important insights for clinicians. So over to you, Kanita. Thanks very much for addressing us this afternoon.
Thank you, Graham. You can hear me?
Yeah, I can hear you fine.
Yes. Great. Thanks very much for that introduction. So I've kept the background very short. Coronavirus disease, we know, is a novel viral pneumonia which emerged in the city of Wuhan in China in December of 2019. The causative agent identified was SARS-CoV-2. Declared a global health emergency in January 2020, and then subsequently a pandemic in March 2020. And I just have to say that on that date, we only recorded, I think, 13 cases, all of which was imported in South Africa. And the latest that we have now is over 34,000 confirmed cases throughout South Africa and over 700 deaths. This was as yesterday, the 2nd of June. So because of this rapid spreading and very limited testing, initially the imaging was used as a diagnostic tool in China. So we've got a lot of literature which came from China and Iran with varying range of sensitivities and specificities. But interestingly, some very characteristic CT findings, which I will discuss shortly. But very importantly, to note that a negative CT does not exclude COVID-19. And I think this is a really important message, and I'll bring this up again later. And this was found particularly in the very early stages in up to 50% of cases with either minimally symptomatic patients. So important to remember this. So of course the radiology societies all came out and came up with position statements. The SDR said that they do not recommend routine CT for the screening, and by far, I think mostly we are actually following these guidelines. Confirmation with viral testing was required, even if the radiological findings was very suggestive, and of course specifically in this current pandemic. And again, very importantly, CDC said to note that normal CT does not mean that you don't have COVID-19 infection. So not to let that sway you if the patient is under investigation. The Fleishman Society, which is our big society in radiology, came up with a consensus statement. And again, by far, I think we are actually following these guidelines. Imaging is not indicated in patients with mild clinical features. Imaging is indicated in patients with COVID-19 with worsening respiratory status. And for us, particularly in resource-constrained environments, imaging will be indicated for triage of patients with moderate to severe clinical features and a higher probability of disease. So the frequently reported common findings on chest radiography and CT is that of ground glass opacity, consolidation, linear opacity, crazy paving, reversed halo, and I'll explain all of these shortly. Predominant, mainly bilateral changes, more than unilateral, although unilateral changes often seen in early disease, particularly only on the chest radiograph. Mid to low zone predominance, and very striking peripheral changes. We of course see more central disease, particularly in patients with increase as the disease progresses. With increasing severity, we see increasing total lung involvement, and this has been demonstrated in many studies. Before I move on to the science, I thought I'll just quickly go through the normal secondary lobular anatomy, because this is the basis of our CT interpretation. It's the smallest unit marginated biconnective tissue sector, and we see it on the left-hand side on the upper image on the CT, often exaggerated, of course, by the disease process. The secondary lobule is supplied by the terminal bronchial, which ends in the respiratory bronchial, is surrounded by numerous acini and alveolar ducts and sacs. So ground glass opacity was the commonest finding on CT. Ground glass, as you can see in the image, is unpolished glass, and that's what we see on the chest radiograph and the CT. So the definition is that of hazy increased lung density on the chest X-ray, where vessels can still be seen, but may be indistinct. On CT, you can be a little bit more specific and say that there's increased lung density with preservation of both vascular and bronchial walls. So you can still see the bronchus, the wall of the bronchus and vessel clearly through this area of increased density. The same pathology can of course progress. And the next slide shows consolidation. So when that same process, whether it be the fluid or cells, extends, and this process now completely replaces air to such an extent that the lung becomes completely solid. And you can see in this image that this is a completely opacified segment of lung. You can see the bronchus, so this is associated with an air bronchogram sign because the bronchus is patent and the air within that bronchus stands out against the very solid background lung. The next finding is that of crazy paving. So crazy paving is where you see interlobular septal and intralobular interstitial thickening superimposed on ground glass opacity. The image at the top to the left is a patient with an interstitial lung disease, so it's a very common finding in ILD. In fact, one of the commonest causes of crazy paving is congestive cardiac failure. We don't often do CT for those patients. And in the image below is actually a patient with active COVID-19 pneumonia. And we're seeing geographic areas of ground glass with superimposed interstitial, giving us that crazy paving appearance. The next imaging finding is that of a linear opacity. These can be lines or band-like opacities. They can often represent areas of linear atelectasis or even thickened interlobular septa. As you can see on the chest radiograph above, they're mostly horizontal, obliquely orientated areas. On the CT, you can see how that is made up. You have areas where the lung is partly, there's a little bit of atelectasis and there's interstitial thickening, giving you those linear opacities on the chest X-ray. The reverse halo sign, or the so-called axial sign, is a focal area of ground glass opacity, often round, surrounded by a ring, which can be complete or incomplete with consolidation. The image at the top was a patient with confirmed cryptogenic organizing pneumonia. So this was initially described in COP, but we're seeing it in patients with COVID-19 pneumonia. The other finding is that of a perilobular pattern where the disease is pushed to the periphery of the secondary polylobule, and this has also been well described now in COVID-19 pneumonia, and similarly, as I said, described in patients with cryptogenic organizing pneumonia. So this is the Carl Attel. And again, just a couple of images just to demonstrate. Image in the middle is a coronal reformatted CT, and you see in the left upper lobe there's an area of opacification. The central part of that opacification is ground glass opacification, and the periphery is very dense consolidation. The image to the far right shows another area. In fact, it's very similar to the Carl Attel, with an area of lucency in the center, surrounded by a rim, the incomplete rim of dense opacification. The atypical findings described are these common findings in that of lymphadenopathy, pleural effusions. Pleural effusions we see often at a later stage, nodules and bronchial thickening. So I've put in some images. The image at the top shows areas of nodular opacification, in this case also unilateral. And the image below shows a patient who is at quite an advanced stage of the disease with a small left pleural effusion. So the British Society of Thoracic Imaging came up with a reporting template which has been internationally recognized and is now being used. Bearing in mind this is a radiologic classification. So depending on what the findings are, and in the current setting of the pandemic, we could classify radiographs or CT findings as either being classic, probable. We can grade that further into mild, moderate, and severe, depending on the severe, obviously the extent of the disease. Indeterminate classification would be for patients where the findings are atypical. Of course, normal is easy, but remembering that COVID-19, and that should always be added into the report, that COVID-19 is not excluded, especially in the current context. And then last but not least is where findings are consistent with a non-COVID diagnosis. And I've just added some images just to show you when we actually have classic COVID-19 on the radiograph, when we talk about mild, moderate to severe disease. It's often, an eyeball assessment. When you look at the mild form of the disease on the radiograph, it's where you've got more normal lung than abnormal lung, and here we see ground glass opacity in the mid to low zones, which is, as we've said, a very typical distribution pattern. The moderate classification would be where you're seeing a fairly equal amount of abnormal and normal lung, and the severe case is where most of the lung is involved. There's very little normal lung that can be identified. Of course, this patient is also intubated with central line in situ. Okay, good. So that's the end of the didactic talk. And so now we'll carry on with the cases for discussion.
Thanks, Juanita. This is Sean Wasserman speaking. Hi, everyone. As Graham said in his introduction, we're going to present a series of cases to illustrate the different features of chest radiology that we've seen with COVID in our inpatients, in our experience so far. So we're going to cover the spectrum of disease from moderate to severe. We're going to look at a few complications, common comorbidities that we've been seeing, and then finally the very specific case of patients with a false negative RT-PCR test, but very highly suspicious for COVID. So if you can advance, and we'll start with the first case. So this is a case of a patient with mild to moderate COVID to start off with. It was a 54-year-old woman who was previously well with an excellent functional status, known to be HIV negative, and presented with a typical viral syndrome of fever, myalgia, dyspnea, and chest pain for about 8 days before she came to hospital. On presentation, she had a high fever, was mildly tachypneic and mildly hypoxic. She was saturating at 96% on room air with a PO2 of 9.8, but was very comfortable, and importantly was very overweight. Her blood results were all in the normal ranges. So if you can advance to the x-rays.
Just a
Okay, so with this patient, we actually had a baseline radiograph, which was performed 2 years ago. And that was very useful because even though this was a relatively poor inspiratory film on the current admission, you can see the difference in the lung basis. So on the previous radiograph, her lung basis was clear, and now she has increased density. So this is classified as ground glass opacity in the mid to lower zones. It's bilateral. We are still seeing vascular markings passing through, although they may become a little bit indistinct. We don't have any significant consolidation. The heart and mediastinum, probably within normal limits, bearing in mind this is a mobile radiograph, there are no fluid effusions, and there's no significant lymphadenopathy. So in the current context, these findings would be compatible with COVID-19 pneumonia, and I will classify it as a mild to moderate degree of involvement.
So in this patient, COVID-19 was confirmed on RT-PCR from a nasopharyngeal swab. As soon as we got the results, the antibiotics that were started initially were stopped, as was oseltamivir. The patient began to develop worsening tachypnea, although didn't become more hypoxic, and she's currently admitted in the COVID ward on oxygen. Next case, please.
Sean, if I can just make a point there, just for the general audience, that one of the points from this case is that we are not routinely repeating chest X-rays unless we are suspecting another pathology has occurred. So I think that's just an important point from this case. Is we've got the baseline chest X-ray and we'll manage her based on that unless there's another pathology that we're considering.
Thanks. Yeah, and that will come across with the subsequent cases that we'll present. So the second case is a patient with much more severe COVID disease. He's a 49-year-old man who was also previously well, an excellent functional status, HIV negative, and presented with a 5-day history of cough, dyspnea, and fever. On initial examination, he was severely distressed, on a mild tachycardia, at a respiratory rate of 56 breaths per minute. His SATs on room air were 70%, but improved to 97% on a non-rebreather mask, and on that mask, his PO2 was 10. He was also overweight and afebrile. He had, as you can see from the blood results, quite an inflammatory phenotype. So he had a lymphopenia, a very high D-dimer. The upper range limit of normal is 0.25, and an elevated ferritin as well. You can advance to the X-ray.
So this was his radiograph. He has extensive disease. In fact, more than just mid and low zone. It's extending up into the upper zones. It's ground glass, but also areas of consolidation. We're starting to see air bronchogram formation where you can actually see some branching, air-filled structures. The heart borders are still maintained, partial loss of clarity of the diaphragms, but no pleural effusions. So costophilic angles clear. Again, heart and mediastinum looks prominent. It is in mobile form, but no significant lymphadenopathy. So features consistent with severe COVID disease on the radiograph.
So in this patient, COVID-19 was also confirmed. Because of the severity of his illness, the antibiotics and oseltamivir were continued. He had ongoing severe hypoxia on a non-rebreather mask plus a combination of nasal prong oxygen. And with proning, his SATs were below 80%. He was then escalated to high flow nasal cannula oxygen at very high FiO2s and flow rates. So at a FiO2 of 90%, his SATs remained below 90, and he was severely hypoxic, and he's currently in the ward, still in that state, and hopefully holding off from intubation. We can move to the next case, and I'm going to hand over to Tari to present this one.
Hi, this is a gentleman we saw who's 44 years of age, who's previously well. He's HIV negative with an excellent baseline, a frailty score of 1. And he essentially presented to Victoria Hospital with what looked like a COVID-19 pneumonia, as well as a newly diagnosed type 2 diabetic with an HbA1c of 8.1. And his history was all in keeping with what looked like a person under investigation with 11 days of this. And subsequently, his SARS-CoV-2 result came back positive. And due to his nature of his illness, he was transferred across from Victoria to Groote Schuur for further treatment in the form of high-flow nasal oxygen. So on his presentation, we noticed that he was very distressed. He had a pulse of 110 with a respiratory rate of 72 and SATs of 64% on non-rebreather mask and nasal oxygen, the so-called double oxygen. And on those parameters, his PO2 was only 4.4 with a PCO2 of 5.3. His labs, as you can see, his white cell count was a little bit elevated at 13.7. Unfortunately, I don't have his lymphocyte count, but his D-dimer was significantly raised with a high ferritin of 550 and a very high CRP of almost 500. Next slide, please.
So his initial chest radiograph showed extensive disease. We have ground glass opacification, areas of consolidation. So you see denser areas showing early air bronchogram formation. This is both peripheral. It's also central disease. We've lost some clarity of the hilar vessels, particularly on the left. And again, with air bronchogram formation, so consolidation, loss of clarity of the diaphragms, no pleural effusions. Heart and mediastinum was prominent, no significant lymphadenopathy, so features consistent with severe COVID-19 pneumonia.
So when he came in, we started him on therapeutic anticoagulation, and we stopped his antibiotics that he was on. And we placed him on high-flow nasal oxygen at very high parameters of 60 liters per minute, giving him an FiO2 of around 95%, but still his SATs remained at a very low level of 74%. And that's even with placing him in the prone position, and required quite rapid intubation. Once reaching Groote Schuur Hospital, we were watching him very carefully with continual ABGs, and noticed that his CO2 continued to rise in the ward. So he was intubated.
And this is his follow-up radiograph. So he's now intubated with a central line and a nasogastric tube in situ. Now there's further extension. In fact, we're seeing no normal lung at all. There's extensive ground glass opacification. Again, the areas of consolidation, you no longer have the demarcation we saw on the initial study. It's extensive disease. Again, no significant pleural effusion and no significant lymphadenopathy on this radiograph.
And he's subsequently doing all right in ICU at the moment. So yeah, thank you.
Okay, I'm now going to hand over to Linda to present the first case of a series of patients with complications related to COVID.
Yeah, so good afternoon. So we had a 58-year-old woman who was newly diagnosed with diabetes with an HbA1c of 7.7%. She's previously had tuberculosis about 2 years ago, which with a good baseline prior to presentation to hospital. She presented now with a new onset shortness of breath, dry cough, and what she noticed was a new lymphedema with a 5-day history. She was moderately in distress when she came in with low saturations of 84% that improved to 98% on a non-rebreather mask. She had a slightly increased BMI with quite overweight, and she was clinically in right heart failure. So she initially, her blood work was not remarkable with a normal renal function. However, she was HIV positive. We can go to look at the X-ray, please.
So her chest radiograph shows extensive lung changes, ground glass opacity extending from the apices to the bases, denser in the particularly the left, mid, and low zone. And again, showing ear bronchogram formation, so areas of consolidation. She's got a big heart, so we know that this isn't a mobile form, but it is enlarged, and in particular, a very prominent right atrium. She also shows hilar enlargement, and I know that can be a difficult finding or difficult to assess, especially if the disease process extends centrally. But this was, I think, noted on her initial on this radiograph as well. She is, in addition, also a little bit rotated, and she's got a sliver of pleural fluid visible in that right costophrenic angle.
So she was confirmed with COVID-19 pneumonia. She received anticoagulation in the ward with antibiotics stopped on the, at the confirmation of the SARS-CoV-2. She went on to deteriorate a little bit, and she was subsequently placed onto high-flow nasal cannula oxygen and cloned between. She unfortunately was very difficult to wean off the FiO2 of oxygen and further deterioration, even though she was on maximal support of high-flow nasal cannula. So at this stage, we went on to perform a CT scan on her. Next slide.
So these are select images from the CT pulmonary angiogram. And given the chest radiographic findings, the suspicion of pulmonary embolus was high. And it was confirmed on the CTPA. We see extensive central thrombus. This is the pulmonary trunk and the division into right main and left main, with thrombus extending into the right main and causing distension of the vessel lumen, extending into the interlobar pulmonary artery with virtually no opacification of that right lower lobe. You can see on the coronal image the corresponding left lower lobe vessels. So almost no opacification of the right lower lobe vessels. The left lower lobe vessels are also distended, no significant pulmonary emboli. A reported finding in some series of COVID-19 pneumonia shows focal dilation of vessels in areas of opacification. The exact etiology is not quite clear. In this case, of course, with the extent of the pulmonary embolism, the pulmonary vessels are dilated. She also has a significant pleural effusion on the left. So CTPA confirmed extensive acute pulmonary embolism in addition to the COVID-19 pneumonic changes. Sorry, that was the last slide for this patient.
So unfortunately, after her stay, after a day or so after the CT scanner, on full therapeutic anticoagulation, she had a cardiac arrest. And in finding, we actually were monitoring her anti-factor 10A for her fixate dose adjustment, and subsequently we noted that her anti-factor 10A was actually needed fixate to be adjusted for her weight at this point in time, but she had demised by that time.
Okay, next case, please.
It's coming up.
Okay, hi, it's Sean again. So just to remind everyone, I'm an infectious diseases physician at Groote Schuur Hospital. My name's Sean Wasserman. I was asked to reintroduce myself, and the others will do that as well. So this is a complication that we're seeing more frequently with the more patients that are being admitted with severe disease. And thanks to Dion Levine for sharing this case. This was a 65-year-old man who was a known diabetic and poorly controlled with an HbA1c of 11.9 and also a heavy smoker. And he presented with quite atypical symptoms and quite vague and prolonged. So reduced effort tolerance for about 5 weeks, progressing to shortness of breath in the 2-week period before he presented. On his initial examination, he was afebrile and not tachycardic and had a mildly increased respiratory rate, but was quite severely hypoxic with SATs of 83% on room air, which improved to 92% on nasal prong oxygen, but still hypoxic with a PO2 of 7.7 on that oxygen modality, and no other major findings on examination. Really, the only abnormality on his initial blood tests was an elevated D-dimer. Next slide, please.
So his initial radiograph showed bilateral changes. In his case, quite a striking peripheral preponderance of ground glass opacification, areas where it looks a little bit denser and you may be starting to see early air bronchogram inflammation. Similar changes on the left, again predominantly mid and low zone with significant disease showing behind the heart with loss of clarity of heart border and hemidiaphragm. He doesn't have any pleural effusion, he doesn't have any significant lymphadenopathy. These findings are consistent with moderate to severe COVID-19 pneumonia.
So COVID-19 was confirmed in this patient, and on confirmation, as we are frequently doing, his antibiotics were stopped. Because of the severity of his disease and his elevated D-dimers, he was provided with therapeutic anticoagulation. And despite this, he had persistent hypoxia, which was prolonged over 10 days in the ward. And he was requiring face mask oxygen, but the hypoxia was so severe and limiting that he wasn't even able to walk to the bathroom. And this was fairly atypical, and so we repeated imaging to look for any complications.
So this is his repeat radiograph, and we see that there's some progression of his disease. So we see areas where the lung has become denser. We also noting that there's appearance of linear opacities extending to that dense peripheral opacification on the left. Again, these areas of what was previously ground glass opacification now shows denser opacification with consolidation and air bronchogram inflammation, and similarly the changes in the lower zones with loss of clarity of heart borders and hemidiaphragm. In this setting, one would consider superadded infection. We must think about pulmonary embolus with infarction given the peripheral nature of the opacities. And then organizing pneumonia and progression of the disease has been, as we've seen, be demonstrated. So those were the differential diagnoses for this patient. We proceeded to a CT, and CT confirms what we see on the chest radiograph and gives us more information. So dense peripheral opacification with air bronchogram inflammation, and we're actually seeing the bronchus all the way, almost all the way through to the pleural surface. And in a setting of acute pneumonic changes, we usually suggest that there's some bronchial distortion. Here we would even go further to say that there's traction bronchiolitis, because we know that this disease process is not acute, it's just a progression of his disease. Lower down in the basis, the finding is predominantly that of a penilobular pattern of disease distribution at the periphery of the secondary lobule, thicker than the normal interlobular septum, with fairly shaggy margins, and again air bronchogram inflammation with traction bronchiolitis extending towards the periphery of the disease process. There was no pulmonary embolus in this patient. We did, however, note a small pleural effusion which had developed on the left. So extensive bilateral disease with bronchoperipheral and also perilobular pattern, confirming with traction bronchiolitis, in keeping with an organizing pneumonia type picture. No pulmonary embolus.
So a clinical radiological diagnosis of organizing pneumonia was made, and in consultation with Greg Calagaro, our consulting pulmonologist, the patient was commenced on prednisone at 1 milligram per kilogram and had a dramatic response, and within a few days was only on 2 liters of nasal prong oxygen and was able to walk freely to the bathroom. Next case, please.
So Sean, if I can just make a point there, just for the wider audience, that we are not using corticosteroids routinely in patients with COVID-19, but on a case-by-case basis, in a patient like this where there is prolonged hypoxia and radiology supportive of the diagnosis of an organizing pneumonia complicating the original COVID pneumonia, that's where the cases that we would consider this. and obviously where we're not concerned about any other diagnosis after assessment of the case.
So we're now going to present a series of cases, the last few on common comorbidities that we're seeing. So the first one I'll present, a 39-year-old woman who is known to be HIV positive, but failing first-line antiretroviral therapy with a high viral load and a low CD4 count of 105. She completed TB treatment about a year ago and now presents with very prominent constitutional symptoms of weight loss and night sweats, but worsening dyspnea, myalgia, and diarrhea for the preceding few days. On presentation, she had a high fever. She was very underweight and very sick with a tachycardia and elevated respiratory rates. And on room air, her oxygen saturation was 96%, but on very mild exertion in the bed, it dropped to 85%. She had no peripheral lymphadenopathy. Her blood results showed evidence of chronic disease with a low hemoglobin, also lymphopenia, which may have been related to her low CD4 counts, and a normal creatinine and a negative urine LAM. So we can show the X-ray.
So this was her X-ray admission. She has bilateral disease. Ground glass opacification, so very hazy, increased density, and as we actually progress down the lung from the mid to low zones in particular, we see that there's increase, it's getting worse in the bases. In addition, she has linear opacities, and in the background lung, there's also an element of nodularity. She has enlargement of the right hilum, but no pleural effusions. Given her clinical status, these findings could be in keeping with disseminated tuberculosis, so miliary TB, especially in view of the lymphadenopathy. The background ground glass opacification should always make one consider PCP pneumonia. But of course, in the current pandemic, we could not exclude COVID pneumonia, and especially because of the mid to low zone predominance. PCP tends to be more extensive, and we should have expected to see it extending into the upper zones.
So on the basis of a clinical presentation plus that X-ray, those X-ray features, we started her on PCP and TB treatment. The COVID test subsequently came back as positive, so the PCP treatment was stopped because we thought that ground glass opacification was in keeping with COVID-19, and we continued TB treatment, and currently she's stable in the ward. I'm going to hand over to Tari now to present the next case.
Thank you. Just for everyone that's joined, my name is Tari Papabanos. I'm a physician currently doing my training in the infectious diseases department. So I'll take you through this case. So it's a 50-year-old male. He's HIV positive on first-line treatment, doing quite well with a suppressed viral load, and he's also hypertensive and a type 2 diabetic, well controlled with an HbA1c of 6.6. He's had a previous mitral valve and aortic valve replacement, and unfortunately this is complicated by heart failure with reduced ejection fraction sitting at around 15%. His baseline is a New York Heart Association 2 to 3. And essentially his first presentation was on the 13th of May, and it was all in keeping with what looked like heart failure. And unfortunately, the swab from that period of time it is still pending, and it was decided to repeat the swab as well as the chest X-ray to see what was going on. We'll show you now. And he was then subsequently discharged, but a week later after the discharge, he presented again with worsening shortness of breath and myalgia, and unfortunately, he just wasn't coping at home with these social circumstances, so he represented. His initial examination, really not bad. Respiratory rate of 25, SATs of 98% on room air with a PaO2 of 15.5. His pulse was fine, 95, BP also okay, and quite a large gentleman. And clinically, at that point in time, was not in heart failure. His labs, as you can see, he's got a low HB, but that was probably related to a bit of epistaxis that he had from being on warfarin. And as you can see, there is a lymphopenia with acute kidney injury, a creat of 131, which was previously normal. and a D-dimer that was increased to 0.42, but his CRP remains normal. Next slide, please.
So very useful in this kind of patient is to have a baseline chest radiograph. In fact, this was with his initial admission, showing cardiomegaly. He has signs of previous surgery. The background lung shows upper blood diversion, dilated upper vessels. There is increased interstitial thickening. We're seeing interlobular septal thickening, the so-called curly B lines, thickening of the fissure with a small lamellar pleural effusion, tracking up the lateral pleural space. On the subsequent radiograph, we can now see new changes, predominantly peripheral, mid-zone opacification, ground glass, again, with some perihilar opacification, and similarly on the left. And some of the changes that we, of course, see on the initial radiograph is present on that subsequent X-ray. The difference in the or why we would consider infective changes rather than cardiac failure. Cardiac failure would tend to be more central, the typical bat swing appearance with ground glass opacification with perihilar distribution. But in this clinical context, it would be, one would always have to consider failure in addition to infection. Subsequently, some of those changes have actually improved. He still has residual peripheral opacification in addition to the chronic decompensatory changes on the chest radiograph. So I think a nice demonstration of the differences and how we see COVID-19 is predominantly peripheral opacification rather than central changes that we would associate with cardiac failure.
So he was obviously COVID-19. So he was COVID-19 positive, and we just continued DVT prophylaxis. There was obviously a concern of hospital-acquired pneumonia when he came in for his second presentation, but we didn't give him any antibiotics, and we just continued his heart failure treatment and tried to address his social circumstances at home by referring him to the social worker. Thank you.
So for the penultimate case, I'm going to hand over to Linda.
Sorry.
Thank you. My name is Linda Boloko. I'm a specialist physician working in the COVID service. So this last case is a 39-year-old woman who is HIV positive, had recently interrupted her therapy, subsequently starting therapy at a CD4 count of 116. She was then diagnosed with tuberculosis about a week or so later. At that point in time, she had an excellent functional status prior to all this presentation. So she had been on TB therapy, but continued to have worsening shortness of breath with a dry cough and a fever at this point in time, with treatment full on for about a week, and she represented to hospital. At presentation, she was slightly hypoxic with saturations of 92% at the respiratory rate of 32, which then improved to 99% on nasal prongs. She was slightly overweight. In terms of a laboratory workup, she had a low hemoglobin of 8.1 with lymphopenia that was seen on that differential count of the blood count, but the creatinine was normal. We went on to do a chest X-ray.
Yes, so her chest radiograph demonstrates unilateral disease. She has enlargement of the right hilum, which is confluent with this area of consolidation in the right lower lobe. We have loss of clarity of the right heavy diaphragm, and it also extends partially into the middle lobe with loss of clarity of the right heart border. So predominantly unilateral disease with associated hilar enlargement, indicative most likely of lymphadenopathy. In the clinical contents, lymphadenopathy with consolidation equals tuberculosis. In our immunocompromised patients, a primary form of tuberculosis. So these findings would be atypical for COVID pneumonia. We do certainly see unilateral changes in early disease, but this is fairly extensive classification with very little, if anything, on the left.
So she was, as mentioned, she was confirmed COVID-19 pneumonia. She who was started on anticoagulation, but there was also a concern that she may have a community-acquired pneumonia, so we continued her intravenous antibiotics and she received a TB therapy. She improved on this therapy onto nasal pumps and subsequently went off onto room air, and the only thing was that she had ongoing fever and a tachycardia, so she was thought to be having ongoing TB iris despite all this therapy, but she remained stable and was discharged following improvement.
Okay, and here's the final case, just to illustrate this problem of false negative tests in someone with a very high likelihood of COVID. A 68-year-old man who was previously well, with an excellent functional status, presented with typical symptoms of cough, fever, shortness of breath for 10 days. On initial examination, he was afebrile, but fairly distressed with a respiratory rate of 32, hypoxic with SATs of 90% on nasal prong oxygen and a PO2 of 7.4. He was overweight, but not in heart failure, and no other significant abnormalities found in examination besides an elevated blood pressure, which was newly diagnosed, and left ventricular hypertrophy on an ECG. His lab results were highly abnormal, with an elevated total white blood cell count of 22, mainly made up of neutrophils. He had a very, very high D-dimer of more than 5, an elevated C-reactive protein, troponin as well, and was HIV negative.
So his chest radiograph initially showed ground glass classification, which is predominantly mid to lower zone in distribution. Denser within the lower zones with air bronchogram behind the heart, so consolidation. Also, loss of clarity or blunting of the costophrenic angle, which would suggest a small pleural effusion. The heart and mediastinum is prominent. This is a mobile fold, but no significant lymphadenopathy. And again, quite prominent hilar areas. And in these patients, one would always be concerned about, if you're worried about pulmonary embolus, whether we've actually got distension of pulmonary vessels. So features consistent with a moderate to severe COVID pneumonia.
So this patient subsequently had 2 negative RT-PCR tests on nasopharyngeal swabs. A sputum was sent and that result is pending. We initiated empiric anticoagulation because we were convinced that he had COVID-19. Because of his high neutrophil count, we completed a course of antibiotics. He remained persistently hypoxic but stable. And because of the diagnostic doubts, chest imaging was repeated with CT scanning.
So his follow-up chest radiograph shows progression of disease. The lung volume has actually decreased. The density of the opacities have increased and is now more extensive, going all the way up to the apices. Again, with air bronchogram inflammation, loss of clarity of heart borders, and heavy diaphragms. He went on to have the CT, and the CT confirms those pulmonary changes. We see mixed density opacification, ground glass, and consolidation. The consolidation often seen at the periphery, so giving us somewhat reversed halo sign. Areas of dense consolidation with air bronchogram inflammation. And then lower down as we proceed, and you can see I've added the soft tissue setting that we actually confirm pulmonary emboli in the middle lobe as well as in the lower lobe on the right, with extensive and denser changes within the lung bases. In addition, we're also seeing bronchi quite far out to the periphery. So very extensive pneumonic changes in addition to pulmonary emboli confirmed on the CT scan for this patient. So, do you want to add anything else to that case, Sean?
No, the patient's currently in the ward and stable, and yeah, that's the end of the case presentations. Thanks.
So, Sean, I think just to kind of highlight the fact that we've had a number of patients who've had a very compatible clinical and radiological picture of COVID-19. And have had 2 nasopharyngeal swabs negative for COVID-19, but based on a very convincing clinical and radiological picture, we have regarded those patients as having COVID-19 and managed them as such.
Thank you, Graham. So I think in conclusion, I think we've described the commonly seen features of COVID-19 pneumonia, but just to say that nothing is pathognomonic. In the current pandemic, we should, of course, always consider COVID-19 very high up in the differential diagnosis, including viral pneumonia. And in the setting of our HIV-positive population, a very important differential is pneumocystis pneumonia. And we must always, bear the patient in mind and think about the clinical setting. So thank you very much.
Thanks, Kanita. So just to wrap up, to say that I think it's really been an outstanding session. I want to thank Kanita for sharing her expertise this afternoon. We've learned a lot from you and from Suleiman over the last 2 weeks, and learned more today. And to thank my 3 colleagues, Sean, Linda and Tari, for presenting the clinical cases. I think it really worked very well to be able to view their radiology with that clinical background details of the cases. And as Kanita highlighted, we really have been able to show you a wide spectrum of pathologies, complications, and issues that have arisen unique to our context in South Africa, where we see COVID superimposed on common diseases that we see in our setting that might not have been encountered elsewhere in the world. So just to say that next week, our webinar will occur at the usual time, 4 p.m. on a Wednesday, and we'll be having a presentation on the renal complications of COVID-19 from Nikki Wern from our renal unit at Groote Schuur and UCT. So hopefully you'll join us again then next week. Thanks very much for listening in this week. Thanks, Mark and Wendy.